Welcome everyone to the webinar. We are going to give a minute or so for folks to keep coming in. As you arrive, please do answer the demographic questions, and you might need to scroll down to see all of them. So please scroll all the way down and answer the demographic questions. I see folks still are coming in, so welcome everyone. You'll see some demographic questions pop up if you haven't yet. Please make sure you scroll all the way down so you can answer all of those. Those would be really helpful. Okay. Welcome, everybody. I still see some folks coming in, so I think we'll give folks another 30 seconds or so. Welcome, everybody, to the webinar on gender-affirming hormone initiation and antiretroviral therapy. We will get started in just a second. We're just trying to give everybody a chance to get in and to answer the demographic questions. Okay, so it's about 2 after. Folks might still be coming in, but I think we should go ahead and get started in the interest of time. So welcome everybody to the webinar on gender-affirming hormone initiation and antiretroviral therapy considerations in people with HIV. My name is Tonia Poteat. I'll be moderating this session, and Dr. Hamnvik will be presenting. These are the financial relationships listed here. And these are the specific financial relationships with the presenters, continuing education credits you can see listed here for this session. This slide lists our grant support. And when you're navigating this activity, just keep in mind that the poll questions will pop up in a separate window. And if you have questions, please make sure to use the Q&A button to ask the questions, not the chat. And when you ask questions in the Q&A, please include your full name and institution. All right, with that, I will turn it over to Dr. Hamnvik.
Wonderful. Thank you very much. And I see here from the demographic questions that we have about half of you who have prescribed gender-affirming hormones and the other half have not. So that's really helpful. So I'm going to go ahead and share my screen and my slides. Let's see. There we go. So first of all, thank you so much, Dr. Poteat, and thank you to IAS-USA for inviting me to talk about this topic. So we are going to be talking about a few different things. We'll talk about some of the just basic principles of gender-affirming hormone therapy. We'll talk about some specific considerations in people who are taking antiretroviral therapy. We'll talk about the impact of gender-affirming hormone therapy on cardiovascular health, and then also address some of the common patient requests that we've been getting in the past few months. So we'll start with a pretest question. This is a 24-year-old patient assigned male at birth with HIV that's well controlled on bictegravir, emtricitabine, and tenofovir alafenamide. This patient reports that they have a female gender identity, and wants to start on hormones, but they're worried about interactions. So which one of the following is the best answer? So go ahead and answer, and we'll... We're giving people plenty of time to read the question. Great. So we'll get back to the answer at the end of the talk. Here's our second question. This is a 45-year-old transgender woman, well-controlled HIV, came out as trans about a year ago. They've been on injectable estradiol with spironolactone and have hormone levels that are at goal. She's been satisfied, but find that her breasts are appearing pretty small. She has a pretty broad chest, so she wants more breast development and is asking about progesterone. So which one of the following would be the best next step? Great. All right. We'll get back to these questions, but we are going to be following another patient in today's talk. This is Amber. Amber is 27, designated male sex at birth, but has a gender identity of woman. So she has a history of HIV infection. She's on same regimen here with well-controlled HIV, and is now coming to start gender-affirming hormone therapy. She actually had started to take birth control that one of her cisgender female friends were taking, but decided that it's probably a better idea to get medically supervised gender-affirming hormone therapy. So you'll see me use the abbreviation GAHT. So when she started on the birth control, she also stopped her antiretroviral. She was told that she might get less feminization from the gender-affirming hormone therapy if she stays on her HIV medications. So we'll get back to that. But in the meanwhile, you want to help her and prescribe something for her. And so the question is, which one of the following medications would you prescribe for her? Would you do an estradiol patch? Would you give her a birth control pill? Would you give her a conjugated equine estrogen pill, a progesterone capsule, or leuprolide injections? All right. So we see here the majority are going for an estradiol patch, but a few scattered answers for the other options too. So we'll talk about that, but I'm going to zoom out for a minute and just sort of give a broad overview of how I think of healthcare for people who are trans or transgender and gender diverse, TGD. When patients are coming to seek specifically gender-related care, I think these three buckets are helpful. There's a bucket of confirming the gender identity, assessing for any coexisting mental or physical conditions that might change your approach. There's a second bucket of gender-affirming hormone therapy, which the majority of patients, of course, in my practice as an endocrinologist, will be looking for. And then there are various gender-affirming surgeries that some patients will be seeking. So those buckets are kind of summarizing the gender-specific aspects of care for trans people. But of course, there's a lot of sort of not, let's say, not physician-delivered interventions that can be really helpful also. Things like peer support groups, voice therapy, using breast prosthesis, getting legal assistance with changing birth certificates, those types of things. And then there is the primary care and specialty care that we all need, and that is of course also true for those who happen to be trans. So this is sort of the overview of all of care for transgender people, but sort of zooming in a little bit on the hormones. So there is a bit of a medical evaluation that we do that includes confirming that there is, in fact, gender incongruence. So asking the patient a bit about their gender identity, what sort of journey they've had there. And then we get a medical history and maybe some baseline labs to look for any specific contraindications or risks that might, let's say, change how we approach their gender-affirming care. And then we talk to the patient about what their goals are or what their concerns are with gender-affirming hormones. And as part of that conversation, we have a conversation about fertility goals because most gender-affirming hormone regimens will lead to a reduction in fertility. But we also have a discussion about contraceptive needs all the gender-affirming hormones that we use routinely will maybe reduce fertility, but not enough to serve as contraception. So patients should be advised to keep using contraception if that is needed. We then obtain informed consent. So we talk about expectations and side effects, and that's sort of the big picture. Sometimes I've had patients sort of in the current political climate raising certain concerns. The concerns might be around documenting their diagnosis in the chart or their gender incongruence in the chart. It might be around billing, concerns around using the billing codes for gender incongruence. And I will say, on those two things, I think we're sort of obligated to use the correct language in our chart and in our billing, because anything else would really constitute fraud. And so, that ends up then being a conversation with the patient. How comfortable do they feel with proceeding down this path of getting gender-affirming care? But we do need to document appropriately in our chart. And while there have been suggestions that we could use more generic billing codes, I'm sort of hearing through the grapevine that those generic codes are being targeted for special review by certain insurers and states. So I would not recommend trying to sort of circumvent it that way. All of this is really could be done by the hormone provider, and that's not to say that there isn't a role for a mental health provider. I think a mental health provider can provide a lot of additional help and input around sort of navigating some of the challenges that come with the presence of gender incongruence. So talking about what are your options? Do you want to socially transition? And if so, how do you want to approach doing that in work, or in how do you want to tell your family? Those types of things. It can also help with gender expression, with referrals for hormone therapy, for surgery, those types of things. And provide sort of family support, either in sort of family therapy or other interventions. The mental health provider can also help, diagnose and treat various other mental health concerns, things like depression, anxiety, ADHD, autism, those types of things that are present at higher rates in trans people. So it's always helpful, but it is for adults not a requirement for a mental health provider to be involved in providing before providing gender-affirming hormones. So once that medical evaluation has been done, then we provide gender-affirming hormones. And why do we do that? To me, the goal is summarized here. It's really to help the patient affirm their gender identity by promoting a physical appearance that matches their gender identity, or that at least is more congruent with their gender identity. So that's a lot of what I talk to patients about when it comes to the goals and expectations of hormones. It is the changes to physical appearance. That's not to say that there aren't additional benefits of transgender hormone therapy. And I really like this one study here that I'll take you through. This is a study from Australia where they happened to have a 3-month wait list for their gender clinic. So they got some funding and were able to randomize patients who were referred, in this case for testosterone therapy, randomize them to go into the 3-month wait list or be taken out of the wait list and initiate testosterone therapy immediately. So you sort of had a 3-month period where some people were just waiting to be seen and another group of people were receiving testosterone. And they administered some surveys for gender dysphoria on the left, depression in the middle, and suicidal ideation on the right. And during the 3 months that the study happened, the scores for gender dysphoria, for depression, and for suicidal ideation dropped in the intervention group, the group that got testosterone, while the scores in the control group, that's our standard care group, did not change significantly. So there certainly are mental health benefits to gender-affirming hormone therapy, even though we end up sort of talking a lot about the physical effects. For this patient, Amber is coming in asking for estrogen. And so for estrogen, we have a few different ways of giving it. The majority of you selected estradiol patch, which is the only option that was listed. that is also on this slide. So I agree with those of you that chose estradiol patch. Now, you could have also done oral estradiol pills in this patient. If there are risk factors for blood clots, we might be more likely to go for the patch because it has the lowest risk of venous thromboembolism. But in run-of-the-mill healthy patients, including patients with HIV, you can really choose any of these. I will say that the conjugated equine estrogens are not really recommended as first-line therapy because we can't monitor it with blood levels the way that we can with estradiol itself. And you'll see what's not on here is birth control pills. Birth control pills have ethinyl estradiol, which is an estrogen, combined with a progesterone. And the reason we don't like birth control pills is that it is it is known to be more thrombogenic, so a higher risk of VTE when compared with estradiol. And also the estrogen component of birth control pills cannot be measured in our assays, so we can't really use our assays to figure out the correct dose. So we really don't use birth control pills. And the dose I'm giving you here a sort of a range of doses, and we rarely use the very high dose here, but the dose is really titrated to achieve levels of estradiol in the blood that are similar to those that we see in cis women. So in the background here, you have the blood levels in a group of about 30 or so cis women who are normally cycling, and you can sort of see maybe you remember from medical school or from your previous professional school, the sort of changes in hormone levels throughout a menstrual cycle. So you can see that, and in red is the target level for transgender women. So you can see that it's sort of somewhere kind of in the middle of what a cis woman will see through her cycle. So that's how we dose it. So going back to amber, estradiol patch is our best choice here. We'll get back to progesterone in a minute, and leuprolide injections are not usually used alone, at least. But with that said, so I focus a lot on estrogen, and that is the key part of hormone therapy because estrogen will exert negative feedback on the hypothalamus and pituitary, so essentially reducing the amount of stimulation for testosterone production. So testosterone will go down quite a lot with just estradiol treatment alone. The problem is, though, that unless you're sort of giving estradiol at excess doses, you will typically have much more testosterone still floating around, blocking the feminizing effect of your estrogen. So we typically do need a second agent, and in the US we tend to use spironolactone as our go-to blocker, and that blocks both the synthesis of testosterone and the effect of testosterone at the receptor level. We could use leuprolide, or Lupron is the brand name. It is just very expensive, and so we don't tend to use it very often because of that. Outside of the US, cyproterone acetate is another option, which is a progesterone-like compound, but it is not available in the US. So spironolactone is sort of our go-to, and we tend to go for doses that are a bit higher than what you might be used to from hypertension management or cirrhosis or other indications for spironolactone. But despite that, we don't often see potassium and kidney function issues, probably because many patients are otherwise fairly healthy, and so they're able to compensate for the tendency towards volume depletion and hyperkalemia. But it is something that we do monitor for with spironolactone. So with that regimen of estradiol plus in whatever route you and the patient choose, together with spironolactone or an androgen blocker, you get a whole bunch of physical changes. They're all listed here. And I think the kind of key take home from this is that a lot of the changes take a while to even start to be seen. So it can be 3 to 6 months for most of the physical effects to start to appear, and then they really take a couple of years before you see maximal effect. One in particular that patients are often eager to experience is breast growth, and that is a test of the patients because it really takes a few years. It's also important to know and to tell patients that a lot of things don't change. Things like the kind of more angular bone structure in the face, how tall you are, the voice doesn't change. So that's also part of that counseling and obtaining informed consent from the patient. And of course, estrogen comes with side effects. They're the same side effects that we would expect to see in cis women taking estrogen. So venous thromboembolism is top of that list for sure. In addition, infertility or reduced fertility is something to talk to patients about. If they're interested in fertility, you can certainly offer sperm cryopreservation before initiation of treatment. And then we talked about the potassium issue with spironolactone, and you also do see some adverse effects on weight and triglycerides, which I'll get back to in a minute. So that's kind of, in a nutshell, how we might think about the approach for Amber, who's looking to start on hormones. For someone, just to kind of touch on testosterone treatment. So for testosterone treatment, we use typically testosterone gel or testosterone injections. And those are, again, at various doses, but titrated so that we get testosterone levels that are in the male reference range. Some patients might be eager to have less than complete virilization. And in that case, we sometimes will go with lower testosterone dosing and lower target level just to try to get a more partial set of changes. So these are the most commonly used form of testosterone. I did want to just touch on a few less commonly used forms of testosterone because sometimes patients will ask about these. One somewhat commonly used form of testosterone are the pellets. So the pellets are injected or inserted using a trocar in the subcutaneous tissue every 12 weeks, every 3 months. And a typical dose here can be up to 10 pellets, usually a little bit less than that, like 6 to 10 pellets. It does come with some expected side effects. You can always bleed or get infection whenever you breach the skin barrier, and occasionally the pellets can actually extrude and fall out. It's fairly expensive, and that's going to be a theme for the less commonly used forms of testosterone. The reason they're less commonly used is in large part because of cost. If you look at what happens, this is in cis men, but if you look at what happens to testosterone levels after inserting pellets, you see that there's a big spike after 1 month, and then it comes down again. And here you are at 3 months, where we would typically put in new pellets. In this particular study, they followed some of their patients further out, and so you can see that it continues to fall and is back to baseline by about 6 months. But it's really every 3 months. So it does mean if you choose this, the patient needs to have a procedure every 3 months. A procedure that could leave small scars and hasn't been so popular in the long term for my patients. Once they've done it a couple of times, they sort of realize they don't really want a small surgical procedure every 3 months. Another option would be the capsules. The capsules are testosterone undecanoate. It is not the older form of testosterone tablets that caused liver injury. And part of the way that they avoid this is that the testosterone is formulated so that it is absorbed through the lymphatic system, and therefore it sort of bypasses the entire liver system. It ends up in the lymphatic duct and then is put into the venous system. So that is a big advantage, obviously, but a drawback is that it means it has to be taken with food. And I'm learning a lot about my patients' food habits. Turns out not that many of my patients have regular meals where they feel like they could take the medication regularly twice a day with food. It also has to be food with a certain amount of fat, which is also part of it. So if you just have a small yogurt, that may not provide enough fat for it to be absorbed. It is also a fairly big capsule, so some patients don't like that. It's costly. And then here you see what happens to testosterone levels throughout 1 day. And you can see that it sort of spikes and drops after each dose. So there's a fair amount of swing in the testosterone level as the day goes on. And some patients haven't really enjoyed that. So I have some patients on it, they like it, but not many. And then the final sort of unusual form of testosterone would be the long-acting injection. The brand name here is Avid, or generic is injectable testosterone undecanoate. And it's given as a depot injection intramuscularly. In the US, the dose is 750 milligrams, given first at time 0, 4 weeks later as a loading dose, but then it's every 10 weeks. And the drawbacks with it is it's very high cost. And also it has the specific requirement for additional training in order to prescribe and administer it, because you're injecting a fair amount of an oily substance, and this can embolize to the lungs, causing coughing and hypoxia. It's really rare. It's like 1 out of 10,000, but it is enough to have led the FDA to add this barrier of the REMS training, so it is not widely used for that reason. But however you take the testosterone, you end up with the changes you would expect, and they're listed here. And you can see that these changes also can take a long time to get fully established. But I will also say that patients taking testosterone are typically seeing changes occurring a little bit sooner and a little bit more dramatic. They're often more satisfied at the end of their couple of years of sort of induction of the treatment, because they tend to get much more dramatic changes to their appearance. Of course, breast size doesn't change, how tall you are doesn't change, and that's obviously something to talk to patients about. And with testosterone also, you get a variety of changes that you need to look at for, side effects you need to look at for. Polycythemia, so high hematocrit, is one that we see fairly frequently, usually not to the extent where we need to change anything, but it is something to monitor. Infertility, perhaps, or at least reduced fertility comes up. And then acne and androgenic hair loss are common side effects. So I do a lot of sort of hobby dermatology in my clinic with these patients. There are also some changes here that we'll get back to in terms of weight and lipid profile. And whether it's a patient starting on estrogen, starting with testosterone, we typically see them every 3 months and see how they're doing in terms of their physical changes, where their hormone levels are at, and make adjustments as needed. So that's gender-affirming care in, was it 20 minutes? But we are going to move on to go back to Amber. As you heard, she was concerned about the interaction between hormones and her ART. So the question for you is, which one of the following best describes what to expect if she is started on estrogen? And this is a question you might somewhat recognize from our pretest. All right, so now we have a large majority going with option D, which is that the presence of HIV or taking antiretroviral therapy, antiviral therapy is not going to is not going to interact with the gender-affirming hormones. And I agree with that answer, though. This is some of the data that I think kind of raised this issue again. It was certainly something that came up with some of the older regimens, but with the more, let's say, more modern regimens, though maybe not our current first-line regimens for HIV, we have seen data like this. This is from the IFACT study, where they had a group of patients that had their estrogen levels, estradiol levels measured, either, sort of comparing a time when they were not taking tenofovir, so TDF, emtricitabine, and efavirenz, versus when they were taking the antiviral. And you can see that the antiviral, when taking antiretroviral medications, the estradiol levels were lower. So this has sort of raised a concern, or brought back this concern, I should say. So what do we actually know about the pharmacologic interactions? This is a sort of a busy table, but it sort of summarizes everything that we know about ARVs and their interaction with gender-affirming hormones. So I'll just put in the boxes here. The red boxes are with each of the classes of medications, what happens to the levels of the ART. So does starting on hormones affect your levels of the antiviral? And you'll see for almost all classes, there is no effect. So very straightforward. You don't have to worry about your antiviral. Now, the exception is a top class here, where there have been some studies showing that there might be a slightly lower level of TFV in those taking estradiol, and for those taking testosterone, there might be a small increase in FTC levels. However, this is in the blood, and other studies indicate that the effect at the site of action of these antiretrovirals does not differ. And I think certainly from a clinical perspective, the clinical studies that included transgender people tended to find that you had the same efficacy in terms of either viral suppression or avoidance of HIV infection for the PrEP studies in the trans people who were adhering to therapy compared to cis people who were adhering to therapy. So clinically, it doesn't seem that this first interaction is relevant. So no effect of gender-affirming hormone therapy on antiretroviral levels. But then if you look at the other side of the coin, does antiretroviral therapy affect gender-affirming hormone levels, like hormone levels? And you'll see that there is a significant increase or decrease depending on the class for each of these. Not surprisingly, the enzyme-inducing NNRTIs tend to cause a reduction in hormone levels from increased metabolism, while the others tend to see an increase in hormone levels. So that might seem like a big deal, and then I'll say I kind of don't care. So first of all, I don't really care because if you look at the current first-line regimens, they actually do tend to fall in the groups that don't interfere with gender-affirming hormone therapy. I think this patient, if I remember right, we had them on, was it TDF, FTC, and Bictegravir? I forget exactly which regimen she was on, but it basically did not include any drug from the classes that affect hormone levels. So that's the first reason I don't care. And the second reason I don't really care is I will pick this up. If this is significant, I will pick it up on the hormone levels. So if it turns out that the hormone levels decrease when you're putting someone on efavirenz, all right, well, I'll just go a little bit up on the dose, and then the hormone levels will be back to where we want them to be. So maybe the clinical significance here is consider repeating a hormone level a little bit sooner than expected or than previously planned if you are making a change to the patient's antiretroviral therapy. But we can easily overcome these changes by just adjusting the dose. So in this particular patient, there was no interaction, but even if you choose ones that do interact, it's not a big deal. So summary here is basically what I just said. So this concern, though, comes up enough that in the World Professional Association for Transgender Health, so WPATH, in their Standards of Care 8, they actually made this statement that healthcare professionals should counsel trans patients that ARVs are not a contraindication to gender-affirming hormone therapy. So this patient should stop taking her friend's OCP. She should start on estradiol that we prescribe, and she should resume her antiretroviral therapy. So that's, you were all correct. Option D is the way to go. I will say a question that comes up sometimes is, does this also apply to pre-exposure prophylaxis for HIV? And I would say most of this really applies also to the regimens that we use for PrEP. With the caveat being that we haven't studied on-demand PrEP in patients taking gender-affirming hormone therapy, and there has been some concern that perhaps the reason that perhaps the reason that this initial interaction here is irrelevant in patients with HIV is because they're taking their medication every day. So you end up kind of building up a high enough level to suppress viral replication. But if you're taking it as needed, perhaps for on-demand PrEP, perhaps you're just not building up enough of a level if you're more rapidly metabolizing the tenofovir. So that is a theoretical concern. I would just say we don't have data on this, so maybe avoid on-demand PrEP in patients who are taking gender-affirming hormones. The other thing to be aware is for injectable, actually not just PrEP, but for injectable HIV medications in general, just be aware that some patients have either implants in their buttocks or they have done free silicone injections. And in that case, the buttock would not be an appropriate place for deep intramuscular injections. So just be aware of that if you're going to go for injectable regimens. All right, so we'll go back to Amber, and Amber is knowledgeable. So she knows that she has a higher risk of heart disease by virtue of her HIV infection. And she's wondering, what about gender-affirming hormones? Is that going to raise my risk of heart disease? And so what is the data on this? So I'm going to start with the outcome of interest, which is cardiovascular events. And actually, maybe I'll start with people like Amber, who are trans feminine, so assigned male at birth, but they have a gender identity that's female or more feminine. So there have been three really big retrospective studies that compare the risk of a few cardiovascular outcomes to both cis men and to cis women. So I think those are kind of nice studies to show. And for those taking estrogen, you can see that there is a high risk of venous thromboembolism. We know that, right? Estrogen increases the risk of blood clots. That's known. But if you look at MI and stroke, you can see that the risk of MI and stroke in trans feminine people, it is higher than in cis women, but it's actually about the same for as in cis men. And actually, this one study found a lower risk of MI compared to cis men. So the way I kind of interpret these data is that we start you on hormones. You're still going to carry with you your genetic or whatever, your male risk of MI and stroke. That's how I interpret this. I will say, you can go into each of the studies and see that each of them have some caveats and so on. But this is sort of the best data we have on outcomes right now. So what I would tell Amber is, you should still be considered at somewhat higher risk by virtue of your HIV and probably more of a male risk of cardiovascular disease. If you look at those starting testosterone, how about their risk? Well, in these studies, there was actually no increased risk of venous thromboembolism. But depending on the comparison population, most of the studies tended to show an increased risk of MI or stroke when comparing to women, cis women. So comparing to cis men, though, the risk was about the same. So again, how I kind of interpret this data is, when you start on testosterone, you're getting all the good effects that you're looking for, but you're also assuming a more male risk of MI and stroke. And so again, you should be considered kind of a little bit of a higher risk based on sort of having a male risk. Now, again, there are some caveats to this. Many of these studies have majority sort of younger individuals. So that, as people age, we might get some updated data on this. They're all retrospective and so on. So, we'll keep watching this space. But I think this is an interesting set of data to start off with. And part of the reason we're watching this space is that we know that there are changes to lipids and to other risk factors for cardiovascular disease that occur when you start someone on hormones. So if you look at trans feminine people starting on estrogen, you see actually an increase in the HDL, which is a good thing. In this study, they did not see any change in triglycerides. Other studies have tended to show an increase in triglyceride levels. These are data from the US, and the reason I'm showing that is that there are also data from Europe showing more adverse changes to lipids when you start someone on feminizing hormones. But part of that, we think, is because in Europe they tend to use, or at least tended to use a medication called cyproterone acetate, whereas we in the US use spironolactone as our testosterone blocker. And that difference is probably relevant because cyproterone acetate is thought to have some adverse metabolic effects. So I think it's helpful to just look at European data where the HDL gets better, but the other lipid parameters do not change. For those starting testosterone, though, we do see in this particular study, they saw a decrease in HDL, a higher triglycerides, and you can see sort of a tendency to a higher LDL cholesterol. It was not significant in this study. But other studies have found that to be significant. So testosterone really does change the lipid panel for the worse. And this is sort of maybe part of the reason why people starting testosterone take on a more male risk of cardiovascular disease. So that's on lipids. For blood pressure, we have another study that looked at the follow-up blood pressure after initiation of therapy. And for those starting feminizing hormones, you saw a drop in the systolic blood pressure. And for those starting testosterone, there was an increase in systolic blood pressure. So again, sort of maybe what you would expect. This study also looked at, actually it was a different study, I think, that looked at body weight over time, and also found that body weight, increases over time. And that's sort of maybe true for cis or trans hormones or not. I think most of us tend to gain weight as we get older. So this did not have a cis non-hormone control group. But there was a significant increase in weight in transmasculine and in transfeminine over time. So there certainly are enough, let's say, red flags for cardiovascular disease that I think this is something that we should be aware of, but maybe not so much that we need to be like overly worried about it. Obviously, navigating or managing risk factors is an important part of this. And to manage risk factors, we often use our ASCVD risk calculators to decide, whether someone should start on a statin, for example. All of those that are available right now will ask male or female. So what do you put in? And the answer, I put a question mark here because we don't have ASCVD risk calculators that are specific to sort of trans populations. And there's also great heterogeneity in trans populations because some are taking hormones, some are not. People taking hormones might be some take patches that we think are maybe safer. Others might be on higher doses of tablets. So it's a very heterogeneous population, which also is tricky. I'll say my approach based on the tables that I showed you before, which showed that the risk tended to be closer to cis men than cis women. I tend to look more at the male marker, so I put in the male sex marker and rely more on that number. But that's not based on science, that's really based on kind of my gestalt. It's also based on my bias that I think statins are great, and I think the more I can kind of build a case for starting a statin, the better it is. And then I will also just say, specifically for patients with HIV, we have the results of the Reprieve trial, and based on that study, the recommendation is certainly that everyone with HIV, living with HIV, who's 40 and older, should be taking a statin. And depending on the actual absolute risk, that's either a stronger recommendation or more of a suggestion. But with that, sort of once you hit 40, it may not really matter what the ASCVD risk calculates at. You might just start them on a moderate dose statin anyway. Perhaps you will go for a more intense dose if you found a very high risk, though. So that's cardiovascular disease, but Amber is started on estradiol and spironolactone pills. And now she says, I am concerned about my continued access to hormones. I want to stockpile. So how do you respond to that request? All right, so we have a majority that says, prescribe a year's worth of medication. A few who will give a different form of estrogen, and some that will say that this is illegal. So I think her concern is not unfounded. This map that I'm showing you now is showing you the current status of gender-affirming care for youth. So this is not Amber. Amber is 27, I think. So. But for youth, you can see that we sort of have a tale of two Americas where, 2/3 of the states have laws in place that limit access to gender-affirming care for youth. And then the other third of the states have, still allow such care. So this is for youth, but there's more and more kind of rumblings about extending some of these restrictions to young adults and maybe to adults in general. So I certainly understand her concern, and even more so perhaps than the care itself being illegal is that more roadblocks being put in place. Things like insurance coverage for gender affirming care being restricted, and so on. So it definitely is an understandable concern. But what do you do as the clinician when the patient is asking you to stockpile? It turns out for Amber, she's on estradiol and spironolactone. So those are medications where you can prescribe 1 year's worth. So, if she's taking one pill a day, just prescribe 365 pills. Insurance may not cover it, but she can use a coupon, like a GoodRx coupon type of thing, bring that to her pharmacy and pay out of pocket. And so that is not illegal, but it comes with some financial impact because she has to pay for it out of pocket. And at some point these medications will expire, and so she would also just have to figure out a way to always use the oldest medications that she has. So I think that's reasonable. I have done this for a few patients that have wanted to do this. Could you write a second prescription for a different form of estradiol? You could, but it just seems easier to have her stick with what is working for her. And I would not recommend that she sort of buy it on the internet, because you never know what you'll actually get in that scenario. It's a bit trickier for patients who are taking testosterone. Because testosterone being a controlled substance, you cannot prescribe a year's worth. There are usually restrictions depending on your state that you can only prescribe 1 month worth at a time. I have patients sort of tell me, and I encourage them not to do this, but I have patients tell me that they prefer the 1 ml vial, which is single use, so they get 4 vials per month. But if they're only injecting 0.3 ml, they tell me that they're using this single-use vial 3 times to get their testosterone, but they keep filling the prescription every month. So that way they end up kind of stockpiling testosterone. That obviously comes with some real concerns about the contamination of the vial. And I think you're in much more of a gray zone, sort of on a legal, from a legal perspective. Not that I'm able to give legal advice. So I sort of tell the patients I don't recommend this. I recommend that you use a single-use vial as a single-use vial, but whether patients listen to me or not, that I don't know. So that's the more complicated for testosterone. I think there's also sort of, in terms of restrictions to care, at some point you can also start to think about how can you make the care as accessible, meaning as affordable as possible. And certainly some forms of hormones are cheaper than others. So for estradiol, you might want to avoid the patch if they're paying out of pocket because it's more expensive. And for testosterone, the injections are cheaper. You might want to limit how many labs you get. So really the absolute minimum is usually at testosterone level and hematocrit for those taking testosterone. And for those taking estrogen, it would be an estradiol level, a testosterone level, and a basic metabolic panel if they're also taking spironolactone. So it's a bit more, ways of kind of making it a little bit more affordable. Of course, at some point, you also need to have appointments, and paying for appointments can certainly be a challenge. All right, so that's where Amber was at. She is now 2 years later. She's been on hormones for 2 years, and she's saying, my breasts grew a little bit. Now they've been kind of stagnating. I have an A cup. The past few months, nothing has changed. Should I be taking progesterone? And I'm sure of those who prescribe hormones in the audience, I'm sure you all recognize this request. It's a very, very common request. And part of the reason that we hear so much about progesterone comes from these data that is a study of trans women who were followed for 1 year while taking estrogen. And in this particular study, they looked at the difference in circumference around the chest between where the nipples are and then just below the nipples, just below the breasts, the inframammary fold. And they basically looked at the difference between those two circumferences. And after 1 year, you can see that for most patients, this was 10, 12 centimeters and below. So if you want to go by cup size, after 1 year, it was an A cup or smaller. So that's pretty disappointing, and especially on a chest that is often broader and sort of wider than your more typical female chest. It can sort of be very not proportional to the chest size. So patients are often kind of disappointed by the breast growth, and so you get sort of questions along the lines of, how about if I take a higher dose, or is there anything else I can do? And that was looked at in this study. So they looked at, in the bottom right here, by estradiol level. Did the chest growth differ by estradiol level? And it didn't depend which quartile you were in, you had the same average growth. It also didn't depend on your age, whether you were a smoker, whether you did oral estradiol versus transdermal patch estradiol, the change in weight. BMI was, they had a bigger, the larger people, the people with higher BMI had a larger chest to start off with, and they remained higher than the rest, but did not actually grow any more than those starting at a normal weight. So there really isn't much that we can do with estradiol to optimize breast growth, it seems. So then there is a potential rationale for using progesterone. There's a known role of progesterone in the development of the breast, and specifically also in the development of the nipple and the areola. Progesterone also exerts negative feedback, so it can help suppress your testosterone levels if Spiro alone has been inadequate. Some people will say that they sleep better or that they have better sexual function. And so it turns out in the US that about half of trans feminine patients actually end up taking a progestogen, so a type of progesterone. And when you look at why, this is from 300 trans feminine patients asking why did you choose to start estrogen, it is improved breast development, it is libido and sleep comes up, and then sort of wanting to kind of have the same hormones as someone assigned female at birth might have. So that's the background that our patients have. But in terms of actual research, we don't have research that support the beneficial effects that patients are reporting, in part because of a lack of studies. The studies that we have so far have mostly looked at sleep, and they did not find an improvement in sleep. And then there was also a study from Australia in 2022 that looked at breast development and did not find a difference. But you'll see that this was only for 3 months and just 42 trans women. So a pretty small study. So the lack of data is more of a situation of just not having the studies as opposed to having a lot of negative studies. And then on the flip side, there might be risks with progesterone. Some risks that are often quoted are the risks of cyproterone acetate. Cyproterone acetate, you'll recall I mentioned this is a medication used in Europe and elsewhere to suppress testosterone, but it's actually a type of progesterone. So we use it to suppress testosterone because it has negative feedback on the hypothalamus and pituitary. But it has been linked to certain benign intracranial tumors, specifically meningioma and prolactinoma. So that's a concern. But whether that risk actually applies to other progestins, probably not. This seems to be very specific to cyproterone acetate. So I don't know that we can take that data and extrapolate it to other forms of progesterone. The other concern that's brought up would be the known side effects of progestins used in menopausal hormone therapy. So specifically in the Women's Health Initiative, you found a higher risk of breast cancer and cardiovascular disease in the group that received a progestin. But this was a very much older population with an average age of 63. And the flip side here is that we give progestins all the time to cis women who are looking for birth control. So we give combined oral contraceptive pills, which have estrogen and progesterone all the time, and we don't tend to worry about breast cancer risk or risk of cardiovascular disease. The WHI also used a form of progesterone, like a synthetic progesterone, that we think has higher metabolic risks and higher breast cancer risk. compared to the natural progesterone, which is available pharmaceutically as micronized progesterone. So that's kind of where we're at right now when it comes to data. But and based on those data, you can understand that guidelines can't really recommend the use of progesterone. We just have no data supporting, at least inadequate data supporting routine use. But this is from the Standards of Care 8 from WPATH. They do say that, if you have a discussion with the patient and you collaboratively decide that progesterone is something you want to do, you can do that. You should just reassess the patient after, they say, within the first year to see if they are experiencing benefit. And if they have experienced benefit, then, great. You might want to continue it for a while until they get all of the benefit that they're looking for. But for breast growth specifically, you will get much more bang for your bucks by proceeding to chest feminization surgery or breast augmentation surgery than you will get from any sort of hormonal intervention, including progesterone. But don't despair, there are studies underway, and these are the two big studies that are currently happening. And the one on the right by Dijkman et al. Is from the Netherlands. They actually presented their data in September, and reportedly there were some positive results, but not everything. And I know it's under the article is under peer review right now. So hopefully that means it'll get published in the next, 3 months or so. So we'll hopefully have a little bit more robust data on the use of progesterone in gender-affirming care. But for now, we don't know. So to summarize, and then I look forward to hearing all your questions. But we provide gender-affirming hormones by giving either estrogen or testosterone, and we adjust based on the levels as well as the clinical effect. Progesterone is not routinely used. You can feel totally good about prescribing hormones and ARVs together, though you may want to keep an eye on the hormone levels. But you should be aware of the potential for overlapping cardiovascular risk and sort of be more aggressive about, or be aggressive about managing cardiovascular risk, as I'm sure you are. And then with the current sort of federal restrictions, don't be surprised if you get more questions from your patients about ways to ensure continued access to hormones. And obviously, we need to continue to advocate for our patients. There are some resources here for you, but I'm going to go back to our our pre-test questions, and I think we'll launch that again. All right, great. So we got basically everyone's going for option D, which is the correct answer here. It's the third time you're seeing this question, so I'm glad you all got it right. So the correct answer is that there is that the HIV infection and ART will not reduce the effectiveness of gender-affirming hormone therapy, especially in this patient who's on a regimen where none of the agents actually interfere with gender-affirming hormone therapy. So therefore, the estrogen dose shouldn't need to be any higher. We talked about how gender-affirming hormones do not reduce the effectiveness of ARVs. And we also showed data that estrogen does not seem to increase the risk of ASCVD. It just stays at a male level. And there's no data suggesting that the combination increases the risk of osteoporosis. All right, so here's our second post-test question. All right, and I like it. So we have a bit of a split. We have the majority went for option C, and many went for option A. And I would say so. The correct answer here is first, you should advise her that guidelines do not recommend progesterone. And then you could potentially prescribe a progesterone if you've sort of gone through what we just did, talking about the lack of data, the potential for side effects, but it is reasonable to do a therapeutic trial. And in that case, I usually go with option A as my progesterone regimen. You can go with 200 milligrams at night of the micronized progesterone if you want, but I would probably avoid medroxyprogesterone acetate because it has more metabolic issues. And option D, increasing the dose. I showed you data that at least the level of estradiol achieved did not predict breast development, so that probably isn't going to help. And then switching spironolactone to leuprolide is not, there's no known benefit of that when it comes to breast development. So that is it, and we're right on top of the hour, which is perfect. So we have some time for questions.
First, thank you so much, Dr. Hamnvik, for that really comprehensive presentation. You have about 10 questions right now, so I'm just going to start at the top. The first is from Ben Grin from KC Care Health Center. Can you talk more about your approach to using injectable estradiol as part of gender-affirming hormone therapy? I found that many patients strongly prefer injectables, but I've struggled with wildly fluctuating estradiol levels in patients prescribed injectable estradiol, including very high levels. How do you navigate this, particularly in patients with potential risk factors for VTE, and they list some, and who are adamant that this is their preferred estrogen delivery modality?
Yes, so I am a big, so this is like disclosure, I'm a big fan of injectable estradiol, and we've actually studied that and published on it because it's we had some of the same experiences and wanted to see if we could do it in a better way. So I think injectable estradiol is great. We don't know how the VTE risk of injectable compares to the other routes. Some people say maybe it's lower than oral because you don't have first pass metabolism. Some people say maybe it's higher because you might get more of a peak, like, as you mentioned. But the important thing about injectable estradiol to be aware of is that when the Endocrine Society guidelines were issued in 2017, we didn't have a lot of knowledge about the injectable estradiol. So the doses that are recommended in the guidelines are just wrong. And I would ignore the dosing. The average dose to achieve an estradiol level in the target range is 4 milligrams per week. So I start my patients on either estradiol valerate, which is more readily available, or estradiol cypionate if you can find it. It doesn't really matter. But I start that at a dose of 4 milligrams if I want to go kind of quickly up to a target level, or I might start it at 2 milligrams if I want to kind of start a little bit slower. And it should be given every week. The pharmacokinetics are such that even though you might hear about doing it every 2 weeks, just don't do that. Do it every week, and then you end up with a little bit less of the ups and downs because you're not injecting quite as much. So instead of having these big ups and downs, you have more of this sort of up and downs. And then I personally use mid-cycle levels, so 3 or 4 days after an injection, I get an estradiol level, and I titrate the dose based on that. And that has worked actually quite well without some of the issues that you highlight. And it also works really well to suppress testosterone. So actually, in our study, I think there was something like 80% of our patients had suppressed testosterone with injectable estradiol alone without needing an anti-androgen. So it is pretty effective. You just have to like ignore the doses and just go with what I say.
Excellent.
Yeah.
Thank you. The next question is from Sandra Paella. Hopefully I pronounced that correctly. From Thermo Fisher Scientific. Are there issues with co-administration of hormonal therapy and antidepressants and anxiolytics?
No, I think there is an interaction between estrogen and lamotrigine specifically, and that comes up sort of as a warning, and pharmacists might be concerned about it. So I've actually discussed that a bit with some people more knowledgeable about lamotrigine than I am, and they have no concern about it. They use it often in people taking birth control pills. So, but that will come up, but otherwise, there's no clinically relevant interactions there.
Okay, thank you. The next is from John Weiser at Grady Pont Center. Please discuss management of elevated prolactin levels in
Mhm.
patients on estrogen.
Yes, that's a great question. Um, so first of all, I have started to get I get baseline prolactin levels because it's not that unusual. So before I start hormones, it's not that unusual for that to be a little high if the patient is on like an antipsychotic or something, and it's just nice to show that. And exactly once, but you know how these one experiences will linger with you. Exactly once, I had a prolactin level of 800 before starting hormones, and we diagnosed a big prolactinoma. And I'm very glad I didn't feed that prolactinoma with estrogen. So I do get a baseline level. Now you will typically see the prolactin rise a bit. The first thing is that it's typically within the reference range for cis women. But oftentimes the lab will apply the male reference range because if the patient hasn't changed their legal gender marker or whatever, that's what the lab thinks. So that's the first thing is if you actually apply a female reference range, many of these high prolactins are actually normal. If they're just a little bit high, you know, so let's say it's like 25 or 30, which is just above, depending on your assay, like the upper limit to normal might be 23. I just mostly ignore those, but I repeat the level again in 3, 6, 9 months, something like that. And what I find is that it usually lingers there. This is all assuming that the estradiol level isn't excessive, by the way. So if you were doing the endocrine society dosing of injectable and their estradiol level is 1,000, you know, work on that first, and then you'll see the prolactin come down as the estradiol comes down. But if it stays just a little bit high, that's fine. But if you see creeping up, 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 I will get a pituitary MRI to rule out a prolactinoma that you are inadvertently kind of feeding or making grow by giving estradiol.
Okay, thank you. That's very helpful. Um, John W. has a question related in terms of side effects of hormone therapy. Can you comment on prostate and breast cancer risk and screening in trans women?
Yes, absolutely. I love these questions because I know something about them. Prostate cancer is really rare. The risk is about one-fifth of the cisgender population among trans women taking estradiol. So, so that's great. And you could argue, you know, in cis men, you could argue about the role of PSA screening, which, depending on who you ask, is great or maybe not so great. It becomes even more tricky though if someone is on estrogen and their PSA drops. Because yes, a high PSA would be very significant in that scenario, but most of the time, what is high when it should be almost zero, it gets very tricky to interpret a PSA in someone on estradiol. So what I usually do is that I will, if I get an older patient initiating therapy, I send a PSA at baseline before I even start on hormones. That way I know that, all right, before starting hormones, they did not have anything going on in their prostate that needed evaluation. And while they're on hormones, that risk is going to be pretty low. So I don't actually repeat PSA screening unless they have some symptoms or something. So I don't do screening. I might do symptomatic, you know, referrals to urology if they had any urologic symptoms. So that's for prostate. For breast cancer, so the data shows that your breast cancer risk if you're if you're a transgender woman on estrogen is higher than in cis men, but not as high as in cis women. So your risk increases by going on hormones, but it doesn't increase to that very high risk that we see in cis women. So with that, you could argue about the cost benefit of screening, but what most of us would go for is in accordance with the American College of Radiology, Endocrine Society, and WPATH and UCSF all recommend screening as you would for a cis woman once the patient has been on hormones for about 5 years. So, you know, age 45, if you're 45 and up and you've been on hormones for more than 5 years, you should be getting breast cancer screening. For your transmasculine patients, testosterone treatment doesn't seem to affect breast cancer risk. So if they still have their breasts intact, they should also get breast cancer screening because they still have breasts. On the other hand, if they have had a mastectomy, you can't really screen, but you just need to be aware that any masses need to be evaluated because they could still have some breast tissue left behind that could in turn develop malignancy.
Great. Thank you so much. I love these thorough answers. Um, John W. also had a quick second question. You mentioned calculating cardiovascular disease risk using the male sex at birth. Do you do the same for the EGFR?
The EGFR. The EGFR, so first of all, I think I'm going to tell you my approach. I'm also going to say if you're able to rely on ways of calculating kidney function that does not involve sex, that's probably better. So I know some cystatin calculators, for example, are not as affected by sex, but most of the time we just get creatinine. And what we know about creatinine is that within 3 to 6 months of being on hormones, you will have a significant change in creatinine where testosterone will increase creatinine and estrogen will drop the creatinine. So certainly if someone has been on hormones for 6 months or 12 months or longer, I would use the sex that matches their hormones. And that's probably closer than using the sex that matches their sex assigned at birth. But I will say these are lots of caveats here on all of this, which is, clinically we have to do something, but these are not perfect solutions. So if it's someone that you have like a high suspicion for, you may want to do more direct measurements.
Okay, thank you. Elise Hack from Hamilton County Public Health wants to know the dosing regimen for the 2 prescriptions if you are going to be stockpiling.
Yeah. So I will usually just prescribe it at their current dose. So if my patient is taking estradiol 2 milligrams twice a day, so 1 tablet twice a day, that's what I prescribe. But I prescribe it for then 730 tablets. Instead of usually I might prescribe for 60 tablets or 180 tablets for 1 month or 3 months. So I don't change the actual dose. I just multiply it up to be for a full year.
Okay, great. I think we have time for maybe 2 more questions. One is from George Frohl, who's a PA and wants to know, I have some patients who've injected silicone in their gluteal area, but no implants. Any thoughts on cabin rilpivirine?
Yeah. So in the guidelines, back when we had HHS transgender HIV guidelines and in the WPATH guidelines, the recommendation is to avoid injecting into sites where you've had previous silicone injections. And I would endorse that because you don't know where you're injecting into. If there's a lot of scar tissue, you may not be absorbing it in the expected way. So I would not use any sites that have had previous silicone injections, unfortunately.
Yeah, fair.
Yeah.
And then Lorenzo Williams from the ACTG wants to know if some of the antiretroviral drugs could be contributing to weight gain that was seen in the study that you showed on antiretroviral therapy and gender-affirming hormone therapy.
So I think the study I was showing on weight gain was not for people with living with HIV. It was just for people starting on gender-affirming hormones. Or maybe you're thinking about the weight gain. Right. I think the data showing. So this was a very short-term study. So this was the pharmacokinetic study looking at estradiol levels while taking versus while not taking HIV therapy. That was a very short-term study. They had only been on, I think the entire study was 5 weeks. So they just hadn't been on hormones long enough that I think weight gain had a role to play there.
Okay, thank you. I'm so sorry for the other folks whose questions we didn't get to. There are some really great questions, so maybe if there's another way to get them to you, you can answer them later. But I really appreciate the really thorough answers you gave and the beautiful presentation you gave. But we are going to have to move on to closing now because it's getting close to the time when we're supposed to be done. So I just want to remind folks to do your evaluations. The information on how to claim your CME will be emailed to you by 5 p.m. Pacific time tomorrow. And please provide feedback. That's really important to make sure that IAS-USA is providing the information that you need. Here's some of the upcoming news and activities happening. I'm sure you'll be emailed about that, including Dr. Sag will be talking about going antiviral. A couple of other presentations, chlamydia management, advances in STI vaccines, medical management of people with HIV, a course for non-geriatricians on December 2nd, and the annual virtual course update, emergent challenging Emerging Challenges in HIV Medicine on December 4th. And of course, CROI in Denver in February. Applications are open now. Thank you so much for participating. We really appreciate it.